This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alera, Research Fellow. Today we're looking at a fascinating new study from World Neurosurgery, published in 2026. It's titled, A Proposed Classification and Scoring System Predicting Gross Total Resection of Recurrent and Residual Pituitary Adenoma, a retrospective study.
This is a topic that hits home for anyone who spends time in the transsphenoidal suite. We all know that the first shot at a pituitary adenoma is your best shot. Once you're dealing with recurrent and residual pituitary adenomas, or RRPAs as the authors call them, the game changes entirely. The anatomy is distorted, there's scar tissue, and the surgical goals often become a bit more conservative.
Exactly, Dr. Aris. The study's primary objective was to identify the specific factors that influence gross total resection, or GTR, and postoperative complications, specifically during these reoperations. But the real meat of the paper is that they didn't just list these factors. They proposed a preoperative scoring system to help us predict the likelihood of GTR and guide our clinical decision-making.
That's a critical tool for the residency and fellowship level. When you're looking at a follow-up MRI and you see residual tumor in the cavernous sinus or a recurrence 5 years down the line, the question is always, is a second surgery likely to achieve total clearance, or are we just inviting complications? What did the retrospective data show regarding the predictors of success?
The authors looked at a variety of factors. In RRPAs, the predictors of GTR are often different from primary cases. They focused on how tumor characteristics and previous surgical outcomes impact the current attempt. According to the study, identifying these factors preoperatively allows us to categorize patients into different risk groups using their new classification.
And that's the key. For a neurosurgery resident, understanding the classification and scoring system is about risk stratification. If the score indicates a low probability of GTR, perhaps the conversation with the patient shifts towards adjuvant therapy, like stereotactic radiosurgery, rather than a high-risk re-resection. Alera, did the study mention how this scoring system balances GTR against postoperative complications?
It did. The study emphasized that the scoring system isn't just about whether we can get the whole tumor out, but what the cost might be. They looked closely at the relationship between the factors predicting GTR and the incidence of new postoperative deficits. The goal of the score is to provide a preoperative roadmap so that the surgeon can weigh the aggressiveness of the resection against the increased risk of things like CSF leaks or cranial nerve palsies that often haunt reoperations.
That's an important point for our practicing surgeons. In the redo setting, the arachnoid is often adherent to the tumor capsule, and the normal landmarks, like the medial wall of the cavernous sinus, might be completely lost. If this paper's scoring system can objectively tell us that a GTR is statistically unlikely based on the imaging and history, it gives us the permission, so to speak, to be more targeted in our decompression.
Right, and by using the same wording as the study, they want this to guide clinical decisions. It moves us away from a gut feeling about a case toward a data-driven approach. The retrospective nature of the study allowed them to see exactly where previous surgeons ran into trouble and which tumor configurations consistently led to subtotal resections.
I think for our listeners, especially the medical students, it's important to realize that gross total resection is the gold standard, but in RRPAs, it's often a moving target. This paper suggests that by using a standardized classification, we can be more honest with ourselves and our patients about the expected outcomes.
Absolutely. The study concludes that this scoring system is a viable tool for preoperative prediction. It's about being prepared. If you know the score is high, you prepare for a more complex dissection, or perhaps you even decide that a maximal safety bulking is the better clinical path than chasing a GTR that has a high risk of morbidity.
It's a significant step forward for the field. We've had CNOSP grades for primary tumors for years, but a dedicated scoring system for the recurrent and residual population is long overdue.
It really is. It's a great read for anyone looking to refine their approach to complex cellular pathology.
Well, that's all the time we have for this episode. Thank you, Dr. Alera, for breaking down this new classification for us.
My pleasure.
And to our listeners, keep an eye on those preoperative scans and consider how a formal scoring system might change your next RRPA case. We'll see you next time on the Neurosurgery Hub podcast.